Well, I just thank you for coming. At least this time it's not snowing, and it's not icy outside, and it's not sub-zero. So I remember one time I tried to do one of these in February. It didn't work out too well. Nobody came for obvious reasons. The weather wasn't very cooperative. Well, I hope that you find this interesting talk. It's kind of an idea that I had actually. I've given this talk once before with physicians and PAs and nurse practitioners and nurses in the audience, and I tried to make it a little more user-friendly for people like you. But I think my point here is that it's a discussion about what makes rheumatologists unique. Number one is we're trained to deal with rheumatic symptoms, and we're also very, very tuned in to what's inside joints. And that's the key to making the diagnosis frequently, and that's the emphasis of this talk. It's exactly what is making my joints swell. And we have some very simple, almost antiquated tools, but before these things were developed, many people had no idea what was causing the inflammation in these various joints. And so it's a perfectly simple technique, frequently not performed well by non-rheumatologists. And certainly, I'll guarantee you, the evaluation of the fluid is not done by any other office with this degree of accuracy. When you have specialized techniques and specialized personnel who are trained to look at these things day in and day out, it makes a huge difference in coming up with the accurate diagnosis. Well, my poor friend here, I think his feet are either hurting or he's clinging on for dear life. Either way, I think it's really important that you come up with an answer. Where am I going from here? He's got to make a decision one of these days. That thing's melting, and he's either going to have to swim right, left, or north or south, one of the two, and that's where we're headed. So what we'll do here is talk a little bit about, where's the money? Well, it's in the bank. When it comes to rheumatology diagnoses, it's in the joint. So the bank is really we want to open that door, and I'll show you how we do that. The fluid within the joint is known as synovial fluid, and evaluating that fluid is simple enough if you have the right techniques, but when it's not done properly, it's by no means helpful. Most of the time, I think it's drawn out of most people's joints in most offices, and maybe culture, but for the most part, it's thrown away. But that's a shame. The key is accuracy. Just like out on a trout stream. Steve and I want to do this soon. He's got trout fishing, but if you don't put the fly where you want it or put the needle where you want it, you won't get the fluid out that you really need for analysis, and that's really, really critical. So the key is when you look at the fluid grossly, just pulling it out, bring it out in your syringe, you have a pretty good idea whether it's inflammatory or it's non-inflammatory. And that's a real key differential. And it's amazing how often that isn't even assessed accurately in most physicians' offices. So we take the fluid out by doing a technique known as arthrocentesis. That simply means to take a needle and put it in the joint space, pull out the fluid, and then analyze it properly, doing various things, including cell counts, cultures, analysis of the color, the viscosity. We sometimes do antibody studies on it as well. You can do all sorts of things with it, and I'll give you some of those examples here in a minute. The key, first of all, is if it's a hot, swollen joint, is it infected? So you definitely need a culture. But a lot of things make your joints hot and red and swollen, and so by definition, you have to assume it's septic or infected until proven otherwise. But if it's not infected, then you have to decide what's causing the inflammation. And this is a long list of diagnoses. The point of the slide really is to say that there are a lot of different things that can cause painful, swollen joints, from non-inflammatory to purely inflammatory conditions ranging from autoimmune diseases to paraneoplastic disorders caused by malignancy somewhere in your body, or they may be associated with metabolic disorders like parathyroid, hyperparathyroid, thyroid disorders, chronic liver disorders, any number of viral infections. It's amazing how many things. In fact, there's well over 100 conditions that can make a joint swell. So that's where the challenge is for rheumatologists like myself. That's exactly what's causing it. And the key is to have a good history and physical in your belt. You know, before I ever tap that joint, I'm going to sit down and talk to you long enough to get a thorough history. I'll examine everything on your body, except in genitalia, for example. We don't do that anymore. Back in the old days, that was politically correct. Anymore, we don't. We rely on gynecologists and family docs to do that. But the idea is to be thorough. And one of the things I pride myself in, and our office prides itself in, is being thorough. And as internists and rheumatologists combined, we don't leave too many stones unturned when we're evaluating the patient. The most common things that we see, of course, are things like autoimmune disorders and crystalline forms of arthritis. Forms of arthritis such as spine disease, such as ankylosing spondylitis, psoriatic arthritis, Reiter's syndrome, things of that nature. Lupus and other connective tissue disorders, sometimes gout and pseudogout, which are crystalline forms of arthritis. And then there's a few other systemic illnesses, including sarcoidosis, which can come into play. So we look at these various forms of arthritis, and if they're infectious causes and they're intermittent, we do additional studies looking for Lyme disease, as for example. The key, actually, this is pretty simple to making a diagnosis between inflammatory and non-inflammatory. You just take the time and know what you're looking for. Typical, absolutely normal fluid is clear as bell. You can print through it, it has no color whatsoever, and it has very few white cells in it. The non-inflammatory fluid, which we often see, for example, in osteoarthritis or sometimes lupus patients, you'll see a fairly clear but slightly yellow fluid. It's still quite viscous, very thick, and the cell count can range up as high as 2,000. Now when it's over 2,000 and it's cloudy, and you can usually discern that fairly easily by just looking at it, it can also let it drip. Be careful with all the OSHA requirements anymore of it. The normal fluid will string out and stays really thick, and it'll drip this long before the bottom drop comes out. But if it's inflammatory, it's very watery, and it becomes thin, and it drips rather quickly and doesn't string out. We call that the string sign. And finally, if the cell count's quite high, then it may be infectious. And you can see really high counts in really active rheumatoid arthritis, psoriatic arthritis, forms of infection, staphylococcal infections, sometimes even fungal infections can have very high white counts. So this is our friend Normal, and this is some pictures thanks to Dr. Schumacher at the University of Pennsylvania. He's a rheumatologist there who's spent his lifetime studying synovial fluid and teaching. He still teaches rheumatologists around the world that come from literally everywhere in the world to see his demonstrations and sit in his workshops at the American College of Rheumatology meetings. He's a very famous man who's kind enough to let me show his pictures. The fluid on the right is very slightly xanthochromic. The color is slightly just starting to turn a little bit yellow. Sorry. Sorry. This is a person who has liver failure, who actually has high enough bilirubin that you get xanthochromic looking fluid. That's not common. But in people with chronic liver failure, they get fluid into all sorts of cavities in their body, including their joints. They have ascites inside their abdomen, which is fluid from low protein levels in their blood. And this can happen in the joint as well. Many of you have probably seen these little cysts on fingers. They get little clear jelly comes out of them. And that's synovial cyst fluid. It's very, very thick, and it is not an infectious process, and it's not a cancer. So when you happen to see those little cysts on fingers and other places, when you draw the fluid out, it's really benign. It's not a serious problem. Sometimes slightly inflammatory fluid will clot as well, so that's a bit of a problem for us when we're trying to analyze fluid. Fortunately, that doesn't happen often. So take a look at an example here. This is an interesting case of a woman that I saw a few years ago. She was roughly 60 years of age, and she presented with fever and rash, swollen ankles, knees, didn't have heart murmurs, probably didn't have endocarditis. She had negative cultures in her blood and urine. She was quite ill. The studies for autoimmune disease like rheumatoid factor, antinuclear antibody, CCP, and finally uric acid were all normal. But her sed rate was quite high, so we knew she had an inflammatory process going on. The key was looking carefully at her synovial fluid. We were able to put that under the microscope, identify high numbers of white cells, did not see crystals, but did find these positive staining bacterial chains, which are typical of staphylococcal arthritis. So before the culture was even done, we had a pretty good idea what the diagnosis was. And this is a very important tool, doing a full analysis of the fluid from the joint, analyzing the gram stain, and also doing the culture. The fluid looks really cloudy. It's basically purulent, pussy fluid, and typically it's not bloody, although it can be somewhat hemorrhagic on occasion. As you can see, these are two fluids that are also quite cloudy. On the left is gout, on the right is rheumatoid arthritis. Can't read through them. You hold it up to the light and put a newspaper print behind it or something, you just simply can't read through it. And this is psoriatic arthritis, extremely purulent fluid. This is an interesting gentleman that I actually saw over at Bryan Hospital not too many moons ago. He was roughly 70 years of age. He'd been in the hospital for about 3 days with fever and this arm that was just blown up red, hot. It looked like he had roaring cellulitis in that arm. He had really high inflammation studies. The sed rate and CRP were quite high. His uric acid was 9.2, interestingly enough. He had a high white count in his blood, so he was really, really sick. His blood cultures were negative. IV antibiotics after 3 days hadn't done a thing. So that's when they asked me to come over and have a look at him. I took some fluid out of his elbow and his wrist, and lo and behold, even though I had a high uric acid, the crystals inside that joint and that arm were consistent with calcium pyrophosphate crystals. We call that pseudogout. It's typically seen in older folks and can be precipitated much like gout can by intercurrent illnesses, infections, sometimes surgery, or sometimes for no good reason at all. It just doesn't always make sense, but it can be common and recurrent in some individuals. Fortunately, it's reasonably easy to treat the acute phases once you get the answer. Again, the fluid looks very, very thick, very dense. You can't read through it. And these are what the crystals look like. They're really, really quite typical. Some years ago, it became apparent that if you use polarized light and you look at these structures in joint fluid, you can differentiate their color as being positive or negative birefringent. And that's a fancy word to say they're either yellow or blue, depending on which way they sit on the axis of the light. This particular crystal tends to be squared off at the ends, somewhat shorter. If I can make this work, I'm sure you can see what I'm looking at here. There it is. That's a typical rhomboidal shaped crystal, much like this one. Sometimes if the angle's wrong, they don't look quite the same, but there's quite a few of those in here, but that's a classic calcium pyrophosphate crystal. Rheumatologists love looking at those. Now here's another person that I thought was particularly interesting, and again, where the joint fluid was particularly useful. This is a fairly young person, age 40, typical Fairbury person, actually. She was from Fairbury, as I remember. She had kept having recurrent knee effusions. That means her knees would blow up and swell up and be uncomfortable and warm. And she didn't have any signs or symptoms of rheumatoid arthritis or autoimmune diseases, any of the features of lupus or rheumatoid arthritis or psoriatic arthritis. She didn't have any skin findings. Her heart was normal. Everything checked out in her physical. She had basically normal blood work. She had a uric acid level, which is actually in normal range. It was under 6.8, which is the upper limits of serum saturation capability. all the tests for autoimmune disease were normal, including the antibody, again, the rheumatoid factor, the CCP. And her knee x-rays did not show any evidence of chondrocalcinosis, which would imply the possibility of pseudogout, which was that crystal we just looked at, calcium pyrophosphate. But she had a little bit of wear and tear arthritis in her knees, but not much. And it certainly didn't explain why these knees would swell up and get as big as they did and as recurrent as they did. Well, one day I happened to have her there when it swelled. She kept coming in and saying, I said, when you have a swollen joint, you come in, we'll take care of it. And lo and behold, she had elevated white count. And guess what? She had gout. Very interesting process in a woman, rarely seen in a 40-year-old woman. But she had monosodium uric crystals, MSU. And that's what uric acid is called scientifically. And when you can see that, and it's inside the fluid, and it's being phagocytized or swallowed up by white cells, you know that's the cause of the knee fluid. That process, the crystals induce an inflammatory response and draw white cells into the fluid of the joint. So you get a high white count, and when they're running around galloping, chasing those crystals and engulfing them and phagocytizing them, you've got a clear-cut diagnosis, no question about it. This is what they look like. They're very interesting. They're much more needle-like. If they sit around in the test tube too long, they can get a little shorter and squared off because of they gradually become shorter and a little bit square. But as you can see, they're not hard to see with polarizing microscope. And you'll have to, the blue ones are negative birefringent. And if you turn the axis 90 degrees, they turn yellow, and that's positive birefringence. You don't really even need a polarizing scope to see them sometimes. That's just plain ordinary light microscopy. And I'll point out this one, you see it's being swallowed up by a white cell. That's very helpful in diagnosis as well. You may learn how to use this before the end of the evening. Well, this is a typical gout attack. This is podagra. When you see a big red hot toe like that, that's typically gout. A lot of things in the big toe get called gout, but you can have a little bursitis there, you can have osteoarthritis there. You can see the same picture in people with psoriatic arthritis, Reiter's syndrome, all of those, and even infectious arthritis. So just because you think it's gout, when you see a big red toe and red ankle, you still have to prove what it is. Like that term gout gets thrown around readily. Frequently people will have elevated uric acid levels and a big red toe, and the doctors will assume that's gout. That may or may not be true. It can be proven easily if you do the right testing. Simply sterilize the skin, anesthetize the skin and joint as best you can from the outside. Put a small needle in there and get a drop or two of fluid. You don't need much. And you put it on a microscope right away. I walk it down to my lab and look at it immediately with my technicians, and we can usually tell whether we have the proper sample or not and move from there. And again, nice thick, purulent, can't see through it fluid. Now once in a while we tap a joint and it's bloody. The most common reason for me to find bloody fluid is someone's on Coumadin and they walk in with a swollen joint and their INR is a little too high, and I pull old blood out of their knee. It can be from trauma, injury of the joint. If it's traumatized and happens to have some fat cells on the top, the fat cells are not normally seen within joint fluid. If you find that, you in fact have identified a fracture. The fat cells come from the bone. And so when you see blood plus a layer of fat cells, that's a fracture until proven otherwise. Sometimes you get bloody fluid if there's infection, and the sample on the right is a combination of septic arthritis with some bleeding within the joint at the same time. So what kind of crystals can we find? It's actually, aside from uric acid crystals and calcium pyrophosphate crystals, we also see calcium oxalate, seen in chronic renal patients. You can find cholesterol crystals, there's sometimes if someone's gone somewhere else and had their knee injected, you pull the fluid out and they didn't bother to tell you they saw a doctor last week. And if I didn't think to ask the right question, I guess, that's actually happened to me. You can't believe how many times patients will walk in and tell you their knee hurts, and they didn't bother to tell you that last week they were in another doctor's office and had it injected. So anyway, don't do that. That's a bad form. Anyway, steroid crystals have a particular identity as well, and some lipids will actually show up in joint fluid on occasion that can look like crystals. I just wanted to point out that this concept of pseudogout and chondrocalcinosis, I would be willing to bet that 50% of the patients, of you folks here in this room, have chondrocalcinosis in your knee joints. It's very, very common. If I went to the nursing home, all the 90-year-old, 80-year-old folks over there, that percentage would be about 80%. And frequently, they'll get a swollen red-hot wrist. That's the most common story. Wrist, a knee, sometimes an ankle, a foot. And there again, it's frequently thought to be gout. Most of these people have elevated uric acid levels because they have mild renal insufficiency and they're on a diuretic and their uric acid level is too high. So doctors assume it's gout, but it's not. They throw them on allopurinol, and that doesn't necessarily help them because the problem is this crystal and not gout crystals. It's important to know a little bit about this, and one of the things rheumatologists do the minute we see chondrocalcinosis on the x-ray, I'll show you an example of that in a minute, and we find pseudogout crystals or calcium pyrophosphate crystals, we go through the differential medical diagnoses of things that can cause it. Most common, this seems to be age and the association with osteoarthritis, but there are certain entities that will cause it to happen prematurely at younger ages. One of them is an overactive parathyroid gland. You may walk in, your serum calcium is too high. You can do a blood test measuring this hormone level, and these people frequently have adenomas or little growths in their parathyroid gland, triggering excessive amounts of calcium in the serum and these episodes of pseudogout. And also, there's some rare individuals who have excessive iron in their body. They develop hemochromatosis, and they may have liver disorders, and they have typical skin findings, but they also may have episodes of pseudogout as well. There's a rare case or two of low magnesium levels causing this to happen, and also low phosphate levels. And there's some really strong familial tendencies as well in this particular problem. So, back to the simple question. We see a swollen joint, we take the fluid out, is it inflammatory or not? That's the first order of business as I'm looking at a new patient or an old patient, either one, who has a swollen joint that wasn't there before. I'll give you a few examples here just to give you some visual images. This is a nice woman who happens to have tophaceous gout. These are collections of uric acid. Those are called tophi. If you look carefully, there's some little yellowish discoloration. That's typical of tophaceous gout. Most females who have gout are usually over age 60 and have extremely high serum uric acid levels. In the hands, it can mimic rheumatoid arthritis. I had one individual not too long ago show up from western Nebraska who'd been treated for rheumatoid arthritis for quite some time. And so I did a little joint aspiration, looked at her x-rays, and even visually you could see the little yellow pockets of uric acid on the backs of her hand. But I have to admit, if you didn't see the yellow spots and if you didn't know they had an elevated uric acid, she had typical distribution rheumatoid arthritis, swollen joints at the wrist, the MPs, the PIP joints, quite typical of rheumatoid arthritis. But the key was, getting a sample and analyzing it under the microscope. Many patients will have these lumps, and that's a big tophace deposit on their elbow. That's called the electron bursa, and it's a common place for those things to occur. It's always amazing to me how many people have these things and ignore them forever. They'll live with them and live with them and think that there's nothing wrong until one day they start having gout attacks.
What do you do for those when you first notice them?
Well, first of all, it's to make diagnosis, and then we try to control the uric acid level, get it down below the saturation point, and people will start resorbing this crystals out of their tissues. If they're extremely large in the way, you can remove them, but that doesn't solve the real underlying problem. We try to get the uric acid level down, and we have ways of doing that. I can talk about that a little bit more. Typically, once you make the diagnosis, you treat the acute inflammation initially. Once that's quieted down, you keep them on low-dose anti-inflammatories, things like low-dose indomethacin possibly, or colchicine, sometimes even low-dose prednisone if you have to, and gradually introduce your products like allopurinol, Uloric, or Benamid, all of which can help slowly encourage less uric acid production or increase excretion of it through the kidneys. So there are ways to eliminate it. And for me, gouty arthritis is a slam dunk. Once you've made the diagnosis, you can treat this. The amazing thing to me is that either between the patient's lack of compliance or the doctor's lack of knowledge, they don't do it right very often. And rheumatologists know what to do with this disease and how to manage those products. It's just like anything else. I wouldn't know how to do chemotherapy for cancer tomorrow. You know, you need to see someone who knows what they're doing with the right products, and then you can handle this diagnosis. There's also a new drug on the market that actually you give intravenously. It's called Cristexa, and you can drop the uric acid levels from 10 down to 0.5 intravenously, and those tophaceous deposits will disappear lots faster. The only problem with the product is there are a fair number of infusion reactions associated with it, but they're not, most of them are not life-threatening, but they can be managed, but they're not life-threatening unless the patient is terribly ill to begin with. But anyway, it's a new product, and for some individuals who are refractory to the standard treatment, it's an option that we now have. So there are people that have really bad, serious, chronic tophaceous gout. I don't know if any of you have ever seen this, but I mean, I literally have all of my partners, I have these patients who walk in with huge lumps everywhere. Elbows, all over their digits, around their knees, their ankles, their feet, and they're very disabling.
Are these soft, squishy?
They're not real soft. Most of them are pretty firm. Yeah. The elbow bursa can contain any number of other things too. You see those same bursa in rheumatoid arthritis, and they may contain rheumatoid nodule tissue, which is a little more rubbery. There again, if you're not sure, you aspirate a little fluid out of it, put it on the microscope, and you'll know what it is. Yes?
Does the disease need to be active to take the fluid and analyze it?
You know, any fluid that I see, I like to tap it and find out what it is. It's a very useful piece of information. I mean, if you don't know what's causing the joint to swell or the pocket of fluid is, you know, you can take a look at it through ultrasound, you can MRI it, but the only way you really know what it is to take the fluid out and analyze it. And you can do it in acute and chronic situations if you aren't sure what it is. I mean, if I have a patient well-established rheumatoid arthritis, and I know that's what they have, and they suddenly have a new swollen joint, you may want to be sure it isn't an arthritic joint that's become infected. I mean, there's an increased incidence of infection in all the autoimmune disorders, particularly rheumatoid arthritis. It's 7 times greater incidence of infections in individuals with that disease than the normal population. And then many of them are on immunosuppressive agents as well, prednisone or whatever. And so if something flares up, don't assume that it's necessarily the disease. It's nice to be sure. And the white counts in people that are on immunosuppressives are sometimes not as generous frequently, so we culture just about anything we take out of a patient on immunosuppressive agents because their white count may be only 20,000 in that fluid, not 60 or 70,000. So you can't assume that even a lower count excludes infections. So don't culture that at the same time. This is the inside of this joint, and you can actually see these crystals on the surface of the bone inside the joint. It's an arthroscopic knee picture. And likewise, gout inside the knee, you can see in that yellow color that it's kind of yellowish deposits of uric acid, a little bit different color. look at our uric acid crystals. Sometimes we hunt and hunt and hunt until we find just one, but one's enough, particularly if it's inside a white cell. This is another example of how we look at these crystals using a polarizing microscope. Knowing the axis of the polarized light allows you to identify whether it's positive or negative by refringence. Sometimes they're inside the cell and they're fairly short and little squatty guys, but again, you have to have the polarized light to make the diagnosis. Here's some calcium oxalate crystals seen in renal failure patients inside a joint fluid. You can stain it with a stain known as alizarin red, and that helps us determine exactly what it is. These are steroid crystals, and lo and behold, they birefringe as well. And if you're not on your toes, you might think those are gout crystals, but they're not. They're a little bit more irregular, short, and not consistently the same shape. Here's uric acid, again, nice long needle shape. There's a cholesterol crystal, just happen to be in the same joint fluid. A little square fellow in the middle. Dr. Schumacher loves those. In gouty arthritis, you can see that in the region of the joint here, this is a typical big tophaceous erosion of the bone. I see that punched out divot right there. That's quite typical of gouty arthritis. Very destructive form of disease in some individuals. Here's another very big tophaceous deposit of uric acid. It's gnawing away at filling up this bone actually at this point. Another one down here. These look different than the erosions we see in rheumatoid arthritis because they tend to be down away from the joint, what we call juxta-articular erosions. Here's an X-ray that shows areas of chondrocalcinosis. I can see that little snowy snowflake stuff in between these bones. This is down towards the distal ulna at the wrist, and that's a very typical place to see it. You can cause erosions as well, and cysts, and degenerative changes. So this condition is often associated with degenerative arthritis. So very common association. This is kind of a, you can see the chondrocalcinosis in the hyaline cartilage surrounding this shoulder joint. There's a condition known as Milwaukee's shoulder, which is associated with this, and as an acute inflammatory reaction in this bone called the humeral bone. The head of it literally vanishes in a matter of weeks, just from the inflammatory condition involved. This is what we see in the knee. You see all this fluffy stuff in here. That's chondrocalcinosis, or that's the term for it the radiologists like to use. It is basically calcium pyrophosphate crystals on the surface of the cartilage inside the joint. And this is one of my favorite pictures. This is came out of a genitals knee, and you can have 6 cookies if you tell me what that is. Now, what crystal's yellow and which crystal is it? Are you listening? Well, remember I showed you the inside of the knee joint, it was kind of yellow inside there, and the other crystal calcium phosphate was not. Anyway, that's just pure uric acid coming out of this guy's knee. That's the only time I've ever seen that. I mean, it was pretty amazing. I was so surprised when I had Steve take a picture of it and put it on my computer so I could show it to people. That's very unusual to see that much uric acid inside a joint fluid.
So were you able to control that in that gentleman?
This guy was tough. He was non-compliant. He was liked to drink, and He just show up every now and then and want something drained. I could never get him to do anything I wanted him to. The answer is yes. If you have a healthy set of kidneys and good heart, this fellow is difficult to manage. But yes, under most circumstances, with a good compliant patient, you should be able to.
Now, I have a question, Doc.
Sure.
I see, you showed a lot of pictures of really disfigured hands and feet.
Mm-hmm.
Had those folks come in when symptoms first appeared? Could you have slowed that process down? I mean, do people just wait till they're just so disfigured that they have to go see a doctor, or is it just a process that's going to happen no matter what?
Yeah, one of the most amazing things I find about some patients is that some people humans are really willing to tolerate a lot of things before they finally say uncle. I saw a relatively young man not long ago. I think he's 40, 45. He's had rheumatoid arthritis since he was 20. He went to somebody once who gave him some methotrexate. He took 4 doses and stopped and never went back again. When he came in to see me, his one knee was totally shot, absolutely shot. One hip was totally gone. He had deformities in his hands, his wrists, his elbows. He had nodules everywhere, rheumatoid nodules hanging out of his elbows, off of his knees. And I said, "Where have you been?" He said, "Well," I said, "what do you do for a living?" He says, "Well, I'm at home. I work on the computer." He'd managed to his poor wife took care of him. I don't know why she didn't put her foot down and get him out the door to a doctor, but he just didn't want to do anything.
But you're saying that you probably...
He finally decided when his wife took him on a vacation to California and he couldn't walk around the wharf on San Francisco Bay, that maybe he needed to do something. He was so miserable walking after one day of walking that he spent the next 3 days in his motel room without his wife. She went on her way with her friends. He finally decided when he came home that he was going to see somebody. It was pretty amazing. But yeah, these tophaceous deposits, yeah, people live with them forever. And they don't always cause a lot of pain. They just start growing. Until they start having real attacks of gout, they rarely seek advice. But these deposits can start showing up and people look at them and just assume it's okay, they'll ignore them.
Were you able to help him?
Yes, I mean, once we get these things under treatment, you can make them better. If their joints are damaged, you can't repair the joint, it's gone. There's a older gentleman in this town who's a doctoral degree gentleman and professional, very, put together gentleman. He and his wife are an interesting couple, and she has rheumatoid arthritis. She wouldn't see anybody for the longest time. And he had gout. He had all these lumps hanging out of his elbows. They just kind of ignored it or didn't want to do anything until finally his wife came in because she just couldn't function anymore. And what's the dramatically nice thing to worry about is I got her walking and doing everything she wants to do again with the treatments we have for rheumatoid arthritis these days. And I convinced him to let me deal with his gouty arthritis. He didn't even come to see his patient. He just sat next to his wife. I said, "No, there's something wrong with your joints." I think it's time for you to talk to me about what this is. And he's coming around too. So yeah, it's amazing what people would. I have a young man from over by Springfield. Is it Springfield? He came in one day, and that poor guy, he's about 35 years old, and he has so many tophaceous deposits, he can't get his hand any closer than that. And yet this guy's working full time, and he works at a hard job. I said, "Does this bother you?" "No, yeah." Just puts up with it. It's crazy. It wasn't too long ago I saw a fellow who came in. This guy had widespread psoriasis. And he's a fairly young man. He's about 40, 45 years old. He's had psoriasis for 20 years. I mean, he had it everywhere. The hugest one. I could show you pictures on my iPhone that would just shock you. Almost 90% of his body is one big red plaque of psoriasis. And I'm not talking a little bit of psoriasis. I'm talking about stuff that's thick and red and scaling. And he walks across the room and he looks like, what's that character on Peanuts? Dustpan.
Oh.
What's his name? Anyway, he lived with that for so long. His fingers were fused. His joints, here, they don't even move anymore. He kind of has a couple of claws and he manages to do things. He's an employed person. He has a real job. I said, what have you been doing all these years? I can't imagine living with enough arthritis that you destroy your joint and allowed it to fuse completely. That means the bone grows together. It doesn't. It's gone. But that's the kind of thing we see. It's just amazing. And yet, there's the internet, there's public education. I mean, there's, you go Google arthritis and our website comes up immediately. I mean, it doesn't take a lot of, but it's common. People just ignore these problems. They don't want to admit there's something wrong with them. I think once they find out, and they find out there's something you can do, it may not be a cure, but if you can treat it and make your life better, they're very grateful and they're very compliant after that. But I'm still amazed after all these years how people will put up with things and ignore them when there really is something to do. But there's a great, bad attitude out there in the public. I mean, you folks are coming here to listen to someone talk about arthritis, but I can guarantee you the vast majority of people out there still think there's nothing you can do for arthritis. Maybe some of that's changed since all those biological drugs are being advertised on television now, Enbrel and Humira and whatnot. But Mr. Mickelson's out there, golfing with psoriatic arthritis now, taking Enbrel. It's good that that's getting some exposure, but it's always amazing to me how little people understand. I gave a talk once for the legislature back in the old days when the University Club was still open. I had about 40 or 50 of those guys in a room all to myself. I gave them this nice little talk and told them, this is back in the days before biologicals, before methotrexate. I mean, it really was back in the early years of my Lincoln experience. And I thought I did this great little job. This one little guy stood up after I was all done. He says, I know there's nothing you can do for arthritis, but thanks for trying. That's a real story. That's one of your senators, guys. I don't know. It's an enjoyable practice. Those of you who know me know that I enjoy talking to you and I enjoy taking care of you. And it's always a challenge for me mentally and emotionally to deal with each and every one of the patients who come in. And it takes a lot of courage, I think, to come and see a doctor. I have relatives, some of whom I live with, who won't go to doctors until they absolutely have to. I remember my dad wouldn't either. I mean, he was almost dying of a kidney stone one day at home. They finally had to come down with the squad car, the ambulance to get him to the hospital. But anyway, let me finish what I have here. I was just going to talk a little bit about, the idea behind this was the rise and fall of inflammation. I just wanted to point out the major focus for me was to tell you that there are some really useful tools to make the diagnosis, and there's some ever so great tools to treat these things with now that 30 years ago weren't available. Since I've been in practice, and I won't tell you how long that's been, it's really changed my life. I mean, the practice of rheumatology is so much different than it was when I was in training. There's no comparison. And the products that I've had the fortune to help develop over the years in our clinical research department are wonder drugs compared to what we had before. Back in the old days, it was aspirin titers and gold shots and lots of prayer. And thank God Dr. Phil Hench and Dr. Kendall at the Mayo Clinic came up with the cortisone, which is really the miracle drug of the century. If you want, between that and penicillin and digitalis, I think, what would this world be without those three products? Corticosteroids are used in almost every discipline of medicine now, and save lives. Despite their side effects, they make a difference. At any rate, I just wanted to tell you that there are targeted treatments, and I wanted to. So first of all, is the problem mechanical? Is it inflammatory? That's frequently not solved until patients come to see a rheumatologist. If it's a mechanical issue, obviously it might be osteoarthritis, it might be an injury, it might be tenosynovitis. It could be any number of things other than an autoimmune inflammatory arthritis. Typically, we do all sorts of things that kind of make a difference, but a key, I think, is to have an accurate diagnosis, exactly what's causing the symptom. Might require physical, x-rays, ultrasound, MRI scans, whatever. But once we have an idea what it is, then we'll deal with it as effectively as we can. We may employ our physical therapy colleagues, orthopedic surgeons. Sometimes we'll utilize the pain clinic physicians, that sort of thing. For inflammatory symptoms, we'll target the disease. And again, these days, the products we have available make the accurate diagnosis, and your treatment is more definitive than ever. And we use various things, including anti-inflammatory agents, corticosteroids, either orally or intra-articulately sometimes, traditional DMRs, things like methotrexate, sulfidine, plaquenil, Areva, and among others, and then the new biological DMRs, and there's a handful of those on the market now that are quite effective, particularly in rheumatoid arthritis, ankylosing spondylitis, psoriatic arthritis, juvenile rheumatoid arthritis, and so we really have some great. And if you happen to have gout or pseudo gout, we look at the metabolic situation and we manipulate that with the products we have on the market now as well, and we have new ones coming about. So finally, the guy decided to get off his little ice pack and jump over to the big place of ice. So he finally made a decision to take care of himself, go see his doctor, and get a diagnosis. My feet don't want to hurt anymore. Thank you.